Hello, colleagues. In a shock patient, every second counts, and it's a race against time, and often the heart holds the answer. Echocardiography gives us a window into that failing circulation. Today, let's explore how it can move from being just an image to being our first and most powerful decision making tool in the ICU from basics to the cutting edge. Joining me today is Dr. Hatim Soleiman Abumari, a leading voice in cardiothoracic intensive care from Harefield Hospital. I'm delighted to welcome Dr. Hatim Soleiman Abumari to the podcast. He's a consultant cardiothoracic intensive care at Harefield Hospital in London, an honorary senior lecturer at King's College. He's internationally recognized for his expertise in critical care echocardiography, mechanical circulatory support, and cardiothoracic critical care. He also serves on the board of European Association of Cardiovascular Imaging and has lectured widely across the globe. We are very fortunate to have him with us today to share his insight on echocardiography in critically ill patients with shock. Dr. Hatim, welcome and thank you very much for doing this for us.
Thank you very much, Dr. Bharat. It's a real pleasure and honor to be with you in this podcast. Okay, so in the next 20 minutes or so, I am going to go through a practical approach for assessing patients in shock using advanced echocardiography and ultrasound. I have no disclosures in relation to this talk, and I will just briefly outline the presentation, which will include discussing the assessment of perfusion and congestion as the foundation of assessment of shock, the use of Doppler in assessing left-sided and right-sided heart perfusion. We will touch upon the concept of flow tolerance, and we will finish with some take-home messages. We need to think differently when we look at shock because we often looked at shock previously as a binary situation where your patient is shocked or not shocked. But in fact, it is not binary. It's a continuum where you have a spectrum of evolution of different stages in shock. So you basically can think of your patient as they could be in a pre-shock phase where they have reduced cardiac output, but they have not manifested clinically into shock. And this is where I think echocardiography and ultrasound can be very helpful to identify these patients with subtle, cryptic, or subclinical shock before they develop macrohemodynamic evidence of shock. And I will start with a case to demonstrate my approach. 55 years old gentleman was referred to us from another hospital with fever, raised inflammatory markers. He was warm on the edges and sweaty with worsening lactate and worsening base deficit. He was hypoxic. Despite increasing oxygen, he was hypotensive and his troponin was mildly elevated. And you can see with that basic focused bedside transthoracic echo in that left parasternal long axis view that the patient has severely impaired ventricular function. You can see clearly that the contractility is reduced. But in fact, we should not rely on contractility in critically ill patients because they can be misleading. And the main marker for contractility that is very popular is the ejection fraction, is a marker that is validated in outpatient settings and not in critically ill patients. And it is unreliable or less reliable in critical care because this marker is continuously affected by preload, by afterload, by heart rate, which are often changing in the context of shock. And that's why you will not see ejection fraction in any of the definitions of shock. And here you have two examples of two different patients where ejection fraction was misleading. On your left-hand side, this is obviously a transesophageal echo. So you can see the image opposite to what you see with transthoracic echo. On your left-hand side, you have a patient with what seemed to be a preserved or normal left ventricular contractility, but this patient had a profound cardiogenic shock. And if you look at the mitral valve here, you will see evidence of severe mitral regurgitation. And this is in fact, contributing to the cardiogenic shock. And that's why, despite the normal ejection fraction, the patient was in shock because the blood was going backward into the left atrium in ventricular systole, despite or instead of going forward through the aortic valve. And there is also another clue in this clip which explains the cardiogenic shock. You look at the right heart and the right ventricle, it seems unhappier or less happier than the left ventricle. And this right ventricular failure will also contribute to what we see in the left ventricle as the underfilling status and will contribute to the overall reduction of cardiac output. And this is a feature which is encountered frequently in perioperative settings, especially after cardiopulmonary bypass, where you see right ventricular dysfunction. Now we will move our eyes and look to your right-hand side. You will see a completely different patient where the ejection fraction was significantly reduced. You see the contractility is very impaired, but this patient had very stable hemodynamics and very stable cardiac output. So the answer here is not in the ejection fraction. It is in the assessment of stroke volume and the cardiac output. And luckily, we have a very important and sensitive parameter, an easy parameter, which can be assessed by pulse wave Doppler, which is the LVOT VTI. The VTI, or the velocity time integral of the left ventricular outflow tracts. It's a parameter which can be easily obtained by transthoracic echo, by obtaining the apical five-chamber view, and then using pulsed wave Doppler sample volume about 5 millimeters below the aortic valve. And then you will obtain a tracing of the ejection. And by tracing that envelope, you can estimate the distance the blood traveled across the LVOT in a heartbeat. And that distance correlates to the stroke distance, which can give us very useful information on stroke volume, cardiac output, and cardiac index, non-invasively at the bedside. And how do we calculate stroke volume from this? It is by assuming that the LVOT is a cylinder. So if we know the area of the cylinder, which can be easily obtained by echo, and the height of the cylinder, which is that LVOT VTI, or velocity time integral, or that distance, then multiplying the area by the VTI will give you the volume of the cylinder, which is estimate of the stroke volume in a heartbeat. And then multiplying that by heart rate gives you the cardiac output, and then dividing that by the body surface area gives you the cardiac index at the bedside. Obviously, the area is a fixed number, so it will never change in the same patient. But the dynamic number is the VTI, which is a number that is very useful as a dynamic measure of stroke volume and perfusion at the bedside. And the usual average or range, the usual range for the LVOT VTI is around 18 to 22 centimeter. Remember, it's a distance. So the number in unit is centimeters. But there are important pitfalls when we use the LVOT VTI for assessing shock. There are certain important pitfalls which will make it invalid. The first pitfall, which is very important to rule out, is the presence of dynamic obstruction across the LVOT. Because if you have dynamic obstruction or acceleration, that will overestimate the velocity and will overestimate the LVOT VTI, even with shock. And that's why we should not use it to assess stroke volume if there is dynamic obstruction at the LVOT. And this dynamic obstruction is not rare in critical care. It is actually frequently seen, especially in cardiac units, for various reasons, because of vasoplegia after cardiopulmonary bypass. You can also see it frequently with sepsis, with inotropes, with anemia, with fever, patients with very small ventricles and basal septal hypertrophy. These patients are more vulnerable to dynamic obstruction at the LVOT and also at the mid cavity of the left ventricle. How do we see this dynamic obstruction? We always start by two-dimensional echo assessment. As you can see here on your left-hand side, you have an apical four-chamber view, and you have the anterior mitral valve which is behaving differently. You can see that when the mitral valve closes, the anterior mitral leaflet bends toward the septum. In systole, instead of fully coapting with the tip of the posterior leaflet, it bends towards the septum. And that creates a gradient during systole, and it creates the dynamic obstruction, which is seen by continuous wave Doppler. You can see here on your right-hand side a high velocity continuous wave Doppler tracing. The normal velocity by Doppler should not exceed 1 meters per second. And you can see here the velocity is exceeding 4 meters per second, which indicates very high gradient across the LVOT during systole, which indicates obstruction, basically. And you can also see it at the mid cavity of the left ventricle. It is not only about the LVOT, it is also about the mid cavity of the left ventricle. And this is a situation where it becomes a clinical dilemma when we see it in perioperative settings, where you have a very small hyperdynamic obstructive left ventricle. This is a short axis view, and what they call kissing papillary muscles, where the LV is squeezing and obstructive with that high gradient. You can see here the gradient is towards the opposite direction because this is a transesophageal echo. And also looking at the right ventricle here, the RV is not good, which is also contributing to the underfilling of the left ventricle. When we look at the left ventricular function and volume, it is very important to interpret that in the context of right ventricular function because of the interventricular dependence. We should not forget that both the right and left ventricle live in one space, which is the pericardial space. And that's why they often affect each other. And the right ventricular preload and filling affects the filling of the left ventricle. But also remember that the VTI is just a number. It can be misleading if we only use it as a number outside the clinical context. I've just said that the normal VTI, the range is between 18 to 22 centimeters, but you can have a normal VTI in an abnormal clinical context. For example, a VTI of 20, which is a normal number, is abnormal in a patient with sepsis because in a septic patient you would expect to see much higher VTI because of hyperdynamic state. And when I see this VTI of 20 in a septic patient, I immediately think of a mixed cardiogenic and septic shock. Also the same, the VTI, which is normal around 20, is abnormal if you see it in a patient with moderate to severe aortic regurg, because with moderate to severe aortic regurg, you would expect to see a higher VTI because of the increased left ventricular end diastolic volume. And the other important clinical context is the area of the LVOT. Remember that the stroke volume equation is not only determined by the VTI, it's also determined by the area of the LVOT. So if you have a patient with a large area of the LVOT, this can compensate for a smaller LVOT VTI achieving adequate stroke volume. So next time, if you see a patient with a reduced LVOT VTI, before jumping into the conclusion that this patient has reduced cardiac output, make sure you look quickly at the LVOT diameter and area and make sure that they are not enlarged. And the final hint on the LVOT VTI is that it is not specific to the left heart. So if I have LVOT VTI that is reduced, it could be from isolated left ventricular failure or isolated right ventricular failure or from biventricular failure. Is that relevant? I think yes, because you would like to know the chamber limiting cardiac output, which is an important question in shock, in cardiogenic shock, especially if you want to decide for mechanical circulatory support, whether to the left heart or the right heart or both, and especially if you want to give tailored pharmacological therapy to the right heart, for example. You would like to know the chamber limiting cardiac output. So how do we assess and determine the chamber limiting cardiac output? The answer is going back to physiology and looking at the cardiac time intervals. And this is something that can also be done easily by echocardiography. Of course, it requires some expertise, but it is not difficult. You would need to have an apical five-chamber view and put the pulsed wave sample volume midway between the anterior mitral leaflet and the LVOT. And with that, you will obtain in the same trace the filling envelope, which is above the baseline, and the ejection envelope, which is below the baseline. And you are basically estimating the total isovolumetric time, which is the combination of both isovolumetric relaxation and isovolumetric contraction, which is the wasted time of the cardiac cycle. This is the time in which the heart neither fills nor ejects. And in an efficient ventricle, this time should be kept at minimum. So the total isovolumetric time should be less than 12 seconds per minute. And if you see the TIVT more than 14 seconds per minute, that means that there is electromechanical loss of efficiency at the electromechanical level of the ventricle. And this is a parameter that is specific to the left heart. So if you measure the total isovolumetric time on the left heart and you find it normal in a patient with reduced LVOT VTI, then you are certain and confident that the problem is not in the left heart, the problem is in the right heart. And that's the value of it. And this parameter was validated in this beautiful study more than 20 years ago, which was published by the team at the Brompton Hospital, led by the late and great Professor Derek Gibson. And they looked at patients with dilated cardiomyopathy, and they found that this total isovolumetric time had a strong inverse relationship with cardiac output during the butamine stress testing and was a major determinant of cardiac output. This is physiology, and physiology never changes. And the results of the study is as valid today as it was more than 20 years ago. And we applied that in a patient who underwent CABG and had cardiogenic shock, and we wanted to optimize cardiac output by echo-guided pacing optimization. So we set the optimum heart rate of the patient to achieve the best TIVT improvement and the best LVOT VTI. And then we also optimized the AV delay by reducing the AV delay until there was improvement in the ejection time and improvement in the filling time, and consequently improvement in the TIVT. And the final word about echophysiology in shock is another important concept, which is ventricular-arterial coupling, where you are looking at the relationship between the left heart and the aorta, which can also be assessed at the bedside by echocardiography, by having simple clinical and echo parameters, the systolic blood pressure, the stroke volume, and the end systolic volume. And with that, you can measure the aortic arterial elastance and the end systolic elastance of the left ventricle. And the normal relationship between both should be around 1. So if you have a patient with cardiogenic shock, we expect the arterial elastance to go higher because of sympathetic overactivity, and the ventricular elastance to drop because of reduced contractility, and that will cause uncoupling of that relationship and a ratio more than 1. And in this paper, which is currently in press, we looked at optimizing the VA coupling ratio in patients with shock and in various hemodynamic instability situations, guided by echocardiography to optimize the response to various pharmacological therapies, which included vasodilators, vasopressors, inotropes, and even beta blockers. And this is also another important paper which was published almost 18 years ago, which looked at the role of levosimendan, which is a unique inotrope, which also has a vasodilatory effect because it's a calcium channel sensitizer. And in this study, which was performed on patients with ischemic cardiomyopathy, they found that levosimendan was able to restore the coupling of the arterial elastance and the ventricular elastance. And back to our patient, we performed that using that app, which is available for free on the App Store and the Google Play. It's called eye elastance. So you can see here before and after levosimendan. Before levosimendan, the VA coupling ratio was very high, was 3. Remember, the normal is about 1. And then after starting levosimendan, there was significant improvement in the VA coupling ratio with reduction of the arterial elastance and increase in the ventricular elastance. And finally, we should not forget about the right heart because of the critical importance of the right heart in critically ill patients. And because of the various maneuvers we do in ICU, which negatively impacts the right heart and increases the pulmonary vascular resistance. And pulse wave Doppler is very useful in this context in assessing pulmonary vascular resistance and RV cardiac output. And this is a very old, simple equation which can enable you to estimate the mean pulmonary artery pressure just from the acceleration time of the right ventricular outflow tract envelope by pulsed wave Doppler. And here you can also see the effect of inhaled pulmonary vasodilator. In this case, we give inhaled nitric oxide. And you can see on your left-hand side, apologies, the patient had mid-systolic notching. And this mid-systolic notching, this interruption of flow in the middle of systole, indicates high pulmonary vascular resistance. And after pulmonary vasodilator, there was disappearance of the mid-systolic notching. And also looking at the notching and the phenotype and the shape of the right ventricular outflow tract envelope can give us very important clues into hemodynamics. Remember, physiologically, the peak velocity before the notch is determined by the compliance of the pulmonary artery, while the peak velocity after the notch is determined by the right ventricular performance. So if you have a patient with small peak velocity after the notch, that would indicate very poor right ventricular performance, and the data has shown us that this also correlates with mortality. And here you have the example. On your left-hand side, patient had mid-systolic notch with big peak velocity after the notch. And on your right-hand side, you have also mid-systolic notch, but a small peak velocity after the notch. Obviously, the patient on the left is more likely to survive than the patient on the right. And finally, the heart-lung interactions and the importance of understanding the impact of mechanical ventilation on the heart. We know that it reduces the RV preload and increases the RV afterload, which consequently reduces left ventricular filling. And the impact on cardiac output depends on the LV function, because if you have a normal left ventricular function, this normal left ventricle will be preload dependent. So this is a ventricle that is more likely to suffer from mechanical ventilation because the preload of the LV drops when the RV is impaired. But in an impaired, reduced left ventricular function, these impaired ventricles are afterload dependent, and these are the ventricles which are likely to benefit from mechanical ventilation because it reduces the LV afterload and blood pressure, which further improves LV ejection. And finally, also looking at the impact of mechanical ventilation directly on the right heart, as in this case where the patient had acute cor pulmonale from a slight increase of PEEP from 8 to 12 with increased RV diameter, septum is pushed to the left, D-shaped left ventricular cavity, and also reduction of the acceleration time and the LVOT VTI. And we can also calculate another interesting parameter, which is the TAPC, pulmonary artery systolic pressure ratio, which is a parameter that indicates the RVPA coupling. So it correlates the contractility determined by TAPC, which is the longitudinal motion of the tricuspid annulus and the right heart, and pulmonary artery systolic pressure, which is the afterload of the right ventricle. And the normal ratio of TAPC to pulmonary artery systolic pressure is more than 0.31, and it's less than you would indicate uncoupling and reduction of right ventricular performance. And in this case, it was 0.2, so it was significantly reduced. And finally, this is an algorithm that we proposed a few years ago with colleagues at the University of Siena, where we described a stepwise approach to the use of echo in the assessment of different types and different phenotypes of shock at the bedside. And this is a QR code to this open access paper. And this is also another open access work where we describe the use of point of care ultrasound in a practical way to assess systemic venous congestion. It is not only about the heart, but also about the impact of congestion on the splanchnic organs, on the liver, on the kidneys. And in this paper, you will find a practical guidance on how we assess systemic venous congestion as a surrogate for right ventricular preload, and also how do we quantify that. And I believe in that integrated approach. I think echocardiography alone is not enough. We need to combine it with lung ultrasound, systemic venous congestion ultrasound, where we have a holistic view of assessment of perfusion and congestion, which is, as we said in the beginning, the foundation of assessment of shock. And a final couple of words. This is a book we published now about 3 years ago. It is a structured approach in using ultrasound and echo in cardiopulmonary practice, where we integrate cardiac ultrasound, lung ultrasound, systemic venous ultrasound in various hemodynamic situations. And this is a very latest book we published a few months ago with Elsevier, with colleagues in Harvard and Mount Sinai, where we made a deep dive into Doppler hemodynamics because I love Doppler so much, and I believe it is a very powerful and simple tool which can improve the quality of care and assessment of our critically ill patients. And we also just published this new international European consensus document of the European Society of Cardiology on the use of cardiac ultrasound in cardiovascular emergency and critical care. It's also open access, just published, and we describe detailed guidance on what we described in this presentation. My final take-home message, dear colleagues, I hope I was able to show you a glimpse of how echo could help in phenotyping patients of cardiogenic shock. We need to remember the multimodal approach of using heart, lung, and veins. I think the functional hemodynamic echo arena is evolving, and we need to empower it and adopt it because it can really help improving the quality of care of our patients. But obviously, this is an area which requires a lot of work and training and accreditation to ensure our colleagues in ICU are practicing that safely at the bedside. But also, we need to do a lot of work in providing better research and validation to empower clinicians in our dynamic field of practice. And thank you very much for your attention.
Dr. Hatem, thank you for that insightful presentation and for sharing your expertise with such clarity. And I think our audience will agree that you have highlighted and not just the science, but also the art of using echocardiography in shock. So we are grateful for your time and perspective.